This is Selma Schimmel for the Group Room in Las Vegas at the Community Oncology Alliance meeting, joined now by Carol Murtaugh, who's an oncology nurse, administrator at the Hematology and Oncology Consultant Practice in Omaha, Nebraska. Hello, Carol.
Hi, how are you?
How are you?
Good.
We're going to talk about some of the challenges in administering the community oncology practice. And you have a very interesting role because you understand the dynamics both as an oncology nurse, also as an administrator. So you have to have your eye on two balls. So talk to us really about what an oncology nurse administrator does.
I've been with the practice for quite a long time, and I came up from the nursing side, so working with patients, administering chemo, and doing phone triage and working with the physicians, and had a large interest in the business side of the practice and started learning more and more about the reimbursement side from a patient perspective and working with patients for patient assistance. So about 3 years ago, our practice administrator decided to make a change in her role, and the doctors asked me to take over the practice manager role. So now I manage the practice, but in addition to that, continue to manage the clinical side of the practice as well. So the nurses, the lab, and the clinical function also, in addition to the reimbursement piece.
As an oncology nurse that originally focused really just on the clinical side and solely to the patient, what was it like to now understand the dynamics of a practice also from the administrative side?
It was a gradual adjustment for me because I had started working more in a patient advocacy role when I was still doing clinical nursing, and so it was a gradual adjustment as I learned more and more about the changes in oncology reimbursement and some of the challenges that we've seen in the practice with more prior authorizations from insurance companies, less payment from Medicare, some of those type of things. I took a real interest in making sure that we could maintain a viable practice so we could continue to treat patients in the practice from a reimbursement perspective.
One of the themes that became so clearly understood with my discussion with your colleagues that were interviewed here today is that the public may not readily understand how much risk the physicians take since they have to advance all the costs for these therapies, which is not what you think about when you go in for treatment. You're thinking, well, my insurance will ultimately pay for it, and it's so easy to lose sight that the only way you can get your therapy if someone advances the medication to give it to you.
For example, it's interesting you would bring that up because I had one of my nurses come to me yesterday, as a matter of fact, as I was in my office. She wanted to let me know that one of our physicians has decided to start a patient on a new therapy, a drug that's recently been approved by the FDA, and that when she called to order that drug, the bill was going to be $18,000. And so she felt that that was, strong enough that she would come and let me know that because she knew that that was a significant amount of money, obviously, to the practice. So part of our challenge, I guess, as a practice administrator is to make sure that we're taking as good care of the patients as we can, but obviously still keeping the practice viable and making sure that the patients get all the benefits they can from either their insurers or copay assistance foundations or those type of organizations.
What does a practice do if the acquisition of one compound is $18,000?
It's definitely a challenge. The first thing that we do in our practice for every new treatment or every change in treatment for a patient is we make sure that we check with that patient's insurance company to make sure that the patient will have coverage for that drug. If there isn't coverage or the patient doesn't have insurance, then we go to the drug companies, their copay foundations, and try to exhaust all the resources we can to make sure that that drug will be covered.
You see, that's the other thing I think is so important for people to understand is how much behind the scenes work goes on to obtain drugs, to approvals for imaging, all of that, and it is not only a challenge, but it is very time consuming for the doctor's office.
Yeah, in fact, we just got a new list today from one of our payers with effective April 1st, they'll be requiring more prior authorizations on many more drugs that we administer and more imaging tests as well. And in our practice, it's not just a clerical person or a billing person that gets involved, because in many cases they want clinical information. So that has to involve a nurse time, and in some cases even a doctor's time, to help make sure that those treatments are covered. And it just changes the whole function of the staff in a practice with that additional time commitment.
What are some of your goals and your own vision with some of the changes that are now coming rather rapidly to the situation that practices, not only yours, but others are going to be facing?
From our perspective, the area that I'm in, we have many rural locations, and we have to watch those locations very closely because they have a high Medicare population. So we want to make sure that we're able to keep those practices open, because we know many of those patients wouldn't be able to drive the distance to our primary site. And in some cases, we'd ask patients to drive 2 hours for care if we were able to maintain that location. So from a practice perspective, we want to make sure that we're doing everything we can with some of our organizations. One of the reasons I got involved with COA was because I wanted to make sure that we're trying to keep community oncology a good, viable option for treatment, because that's where patients get the best care in the country.
Well, and you've also helped to clarify something, because perhaps it's very easy for people to think when they hear of doctors closing their practices that it's a greed thing. They're not making enough money and whatever, he closed his practice or she closed her practice. But in reality, it's not that at all. And the reimbursement thing, it's so easy for people to perceive reimbursement as the doctors getting wealthy without that very important distinction that no, it's the cost of running a practice, and an oncology practice is really expensive to run.
Especially when I look at my list of drugs that I purchase for patients, and for the Medicare reimbursement at the level it is now, I have almost 40% of the drugs I buy that I don't get reimbursed that amount from Medicare. So that's why I say it's so important for me to track what our Medicare population is, in what location, and how those clinics are doing, because we have to be able to keep our doors open.
Not about what your practice costs, but would you, for the sake of our viewers, give a range of what could it on average cost, let's say a 3 to 6 doctor practice, to operate in this climate?
Just drug costs alone for probably 4 to 6 physician practice would be anywhere between probably $1 million to a little over that a month, and that's only drug costs. So then the staff, remember, in those offices are highly trained RNs. Many practices employ pharmacists, there are lab personnel, there's physicians, and in addition to that, usually nurse practitioners or physician's assistants. So when you add on top of that all the staff costs and overhead, it's a multi-million dollars a month.
What are your final thoughts to your oncology nurse friends and colleagues, as well as other interested parties in oncology? What do you want them to know as someone who's an administrator of an oncology practice?
I think something that changed for me coming from the clinical side is when I tried very hard as a nurse to just take care of my patients and shelter them from all the other, financial pieces and all of those things initially. And I think that was really common for practices, 5-6 years ago. And there's some practices that still find it very difficult to have those conversations with patients. But even though my allegiance is to my patients first and foremost, I think we don't do patients a service by not talking to them about the financial piece. Because even though you're a patient and you've been diagnosed with a disease and that's very difficult to take and you're dealing with all those pieces, it's not fair to a patient to then have that patient all of a sudden be either sent a bill for a huge amount of money they weren't expecting, or find out that their insurance isn't covering their care that they thought they would. And those are conversations I think everyone needs to have with their patients now, and help patients understand this is a crisis. This is an issue where there are patients that can't be taken care of in their private practice setting any longer because of the financial reimbursement and the burden that it's placed on practices. So while it's so important for the patient to get all the clinical pieces that they need for their care, it's important that they understand the financial piece now too.
I agree with you, and I think that it is the one way that it will begin to foster that sense of what can I do, and how do I raise my voice, and how can I be more involved in the issues of patient advocacy, because the partnership between patients and doctors, oncology nurses, and the entire oncology professional team really needs to be cohesive now.
Mm-hmm. We have to all come together as a team now. We have to all start the dialogue and make sure that everybody is on the same page so we can continue to provide the high quality care that we have in the past.
Thank you, Carol. Carol Murtaugh, oncology nurse and administrator of hematology and oncology consultants in Omaha, Nebraska. Very interesting dual situation that you work in. Thank you for sharing your insight and experience with us.
Thank you.